that's directly relevant to our issues with JIA associated uveitis, which I think is still, I suppose, idiopathic.
So that's actually the guidelines that I put as the ACR guidelines. I presented the ACR ones from 2018. It was this paper before it came out. So it's exactly the same guidelines.
I see, okay. So anyway, it's been published now, and it was mainly put on by the pediatric rheumatologists. The ophthalmologists who participated in this were Gary Holland and Ida Sen. And ACR has its own way of doing things. They have an actual guideline process, which is a consensus process, and they have a specific grading system for medical evidence, which includes impact on patients and treatments, which is excellent. And they actually included in this consensus process 2 adults who had previously had juvenile idiopathic arthritis associated uveitis to give their viewpoints in terms of burden of monitoring and burden of screening. So the guidelines are the ones that you are very used to. High-risk features, less than 7 years, ANA positive, disease duration less than 4 years, and then screening every month in that high-risk group, and less frequently if they're less high-risk. Some of the changes are, in this new guidelines, are monitoring while they're on treatment, which is also important. And I've been in the habit of just watching everybody every 3 months, but there's actually now a specific recommendation that if there's any change in their systemic treatment, that they should be examined every 2 months. And if there's any change in their topical corticosteroids, they should be examined every month. And this is obviously related to how quickly you think you would see a response according to a change, whether it's a systemic therapy, which generally has a slow onset of action and is slow to change if you change it, compared to topical corticosteroids, where even a drop or 2 can make a difference. For the first time, they made treatment recommendations for JIA. And basically, the short thing is the topical steroids are the first in and the first out. It's perfectly acceptable to start with topical steroids for mild disease. Prednisolone is preferred to difluprednate because of the risks of complications, and also preferred to oral prednisone in children. But if a child needs more than 1 to 2 drops a day for more than 3 months, they suggest that systemic therapy be added. And the other thing that I think is extremely helpful, particularly for counseling parents, is that if they've had 2 years of well-controlled disease, then you can consider tapering the systemic therapy. It's not just that they've been on treatment for 2 years, but they have to be well-controlled. Now, the other things, there's some other recommendations that they made for treatment. Strong recommendation for subcutaneous methotrexate rather than oral, and I know a lot of parents and kids are going to try to negotiate that. We already knew that monoclonal TNF inhibitors were better than etanercept, and the only high-level evidence was the recommendation to start both methotrexate and a monoclonal TNF inhibitor, which is Humira or infliximab, for severe disease. And that was published, and that's the Sycamore study that was published in the New England Journal of Medicine. And I talked about some alternatives and so forth. But basically, it is still what you're familiar with, which is methotrexate and either infliximab or Humira. And it's interesting. Dr. Goldstein talked about JIA, which is associated with B27 disease. Those kids on treatment with systemic therapy will often have attacks of acute anterior uveitis. The guidelines specifically mention that in that case, even though they're failing, they have active disease, that it's recommended that you add corticosteroids rather than switching immunosuppressants at that point. Okay, so my topic is really intermediate uveitis, but I wanted to go over those guidelines for you because I think they're really important, and I would encourage you to read that paper, which came out in Arthritis and Rheumatism. So for intermediate uveitis, often the kids are asymptomatic, and they may have revealed finally in your office that they've had floaters for 1 to 2 years. I think children are more likely to have anterior segment inflammation compared to adults who present with intermediate uveitis. Blurred vision from vitreous opacities, sometimes they've just been adapting to that. Sometimes we'll have cystoid macular edema, less common than in adults, and sometimes they have vitreous hemorrhages. And so as many as 20% of children can present with a vitreous hemorrhage. These floaters, children just adapt to it. They don't really know what's normal, and as long as they can see well enough in at least one eye, they generally are perfectly happy. So to include a case as being an intermediate uveitis, they must have vitreous inflammation, and virtually, they have retinal vascular inflammation as well. That is how intermediate uveitis comes. It's not really so much a uveitis as it is a retinal vasculitis. They should not have choroidal inflammatory lesions, and the subtype of pars planitis is very specific that they have a pars plana exudate. So the snowbank, as you know, is white, it's precellular, acellular, and it's collagenous. It is not a sign per se of active inflammation, and often it will not change over time, even with treatment, although it may become more fibrotic. The snowballs, on the other hand, are focal vitreous opacities that are cellular. They are always signs of active disease and need to be treated. You can look at the snowbank, please do, mark the clock hours that it involves, and if they have peripheral subretinal exudation, I think it's always important, and if they have neovascularization of the snowbank, it's always important because I think it may result in more complications down the road. So diagnosis is the same as everything else. You use the standard uveitis nomenclature guidelines to determine how many cells in the anterior chamber, the anterior vitreous, how much flare there is in the anterior chamber, how much haze there is in the vitreous. Note the onset, duration, and pattern. Usually this is insidious, persistent, and chronic. You should document that there are no chorioretinal lesions, size and location of snowbank, and any other complications. I think wide field fluorescein angiography is probably the biggest game changer that we've had in intermediate uveitis in pediatrics so far. You get a great panoramic view of the retina. These cameras are much easier for children to tolerate. It's not as many snaps as they need to take with a regular fluorescein angiogram, where there's a peripheral sweep. You need to look at what's leaking, whether it's small vessels, large vessels, and look for areas of non-perfusion, which really should not occur in children with pars planitis. OCT of the macula, I think, is essential and can be tolerated by very young children. Hopefully, it looks perfect. Often it doesn't at onset, but that's one of the very important outcomes that you want to do, what you want to look at. So this is the Fern pattern of small vessel leakage that's associated with pars planitis. Often the large vessels are entirely normal, and it can go all the way down into the center of the retina into zone 1, and gives you, this is a conventional camera, you're really not seeing the true extent of it. In an active case like this, you would of course see it, but if you've only got peripheral disease, as is shown on the right here, you would likely think that the child is okay. They might come in with anterior chamber cells, you do a narrow angle angiogram, you feel like they're probably doing okay, and don't recognize that there's actually an issue. ICG is very helpful in new cases that you see to determine whether or not there are choroidal lesions that you really can't detect with your naked eye. Sometimes they don't have a color to them, so this can be very helpful. Stereotypical cases are usually bilateral, 85%. They have a snowbank, it's a young person, and you can feel pretty comfortable that they don't have a systemic association. Sarcoid does occur in children, and there may be other causes for retinal vasculitis. Multiple sclerosis would be one. That's much more common in adults. Lyme disease is reported in other parts of the world, not so much in the United States, and the presentation of sarcoid is a little bit different. As Dr. Goldstein said, no CT scan. Still, even if they're not totally typical intermediate uveitis, 70% of cases are still idiopathic. Here's a case of MS. Often they present first to you, and 5 years later, as in this case, they are diagnosed. So there's a new treatment stipulated for pars planitis. I start with medical treatment. Sometimes we'll go to peripheral retinal ablation, and I think vitrectomy surgery can be marvelous in kids to try to break the cycle of medical treatment if there's no other way to get them out of it. This is possibly acceptable leakage that could be observed. This is also very minimal disease that you would likely choose to observe, even with a snowbank. This is something that you would always treat. It involves zone 1. The medical treatment is an immunosuppression, obviously, but it often works slowly or poorly in intermediate uveitis compared to other types of uveitis. Methotrexate is the usual starter drug, and Humira is effective, markedly effective in some cases, but not all. So here's an example. This is presentation, leakage in all 3 zones, treated with corticosteroids, the methotrexate and adalimumab, and at 2 years, he's completely quiet. And if you extrapolate from the JIA guidelines, you make sure that he was quiet for 2 years, and then you would start tapering him off. Here's another example at presentation, all 3 zones. The retina is thick on the OCT. Look at the map, not just whether or not there's cysts. It's actually abnormal, and the retinas will thin out. He had quite substantial anterior segment inflammation. fellow eye was less severe. Bridge steroids, 3 months only. Methotrexate, adalimumab, resolution after 2 years. Now, when do you get into surgical treatment? It can be both corticosteroid sparing, immunosuppression sparing, always combined with peripheral retinal ablation, which is in the inferior zones. This is a good pattern to memorize, and that's what your peripheral ablation should look like when you get done. This is the wrong way to do laser. You would never place posterior laser. It's not effective. It does not get those peripheral areas of leakage that is your target for ablation, not the posterior retina. It is the peripheral retina anterior to the equator. And almost in all cases, this is going to be combined with medical treatment. So I had some natural experiments here. Non-vitrectomized eye on the left, vitrectomized eye for vitreous hemorrhage, doing much better on medical treatments. The vitrectomized eye has a durable remission after treatment is withdrawn. Here's another one. Vitreous taken out at the time of a white cataract being removed in childhood. Its retina looks great. The other eye has active inflammation. Here's another example in which surgical therapy had worked very well. Methotrexate for 2 years, still active, vitrectomized, goes completely quiet. Bilaterals, though, basically in remission forever, 2020 and off. This is probably the only type of uveitis that you can have an actual remission from a surgical procedure like vitrectomy. So we'll skip over some of these things. Let me just show you and go quickly so we can get onto the masquerades. VKH in children is often extremely severe with subretinal fibrosis. This girl eventually developed choroidal neovascularization, which has been very difficult to treat, and her vision is 2300 in the right eye. Sarcoid, it has the same type of presentation that you would see in adults. Systemically, however, it has a different pattern that you should be aware of. I don't think I've ever seen a case of sarcoid uveitis in a child in which the child did not already carry that diagnosis. Here's some sarcoid granulomas, very beautiful, and then these tiny punched out spots in the periphery. You can also see this in Blau, and you can see it in Tinea. Here are the characteristic joint deformities in the hands for Blau disease. And unfortunately, multifocal choroiditis, panuveitis, and subretinal fibrosis also occurs in the pediatric age group. This is a Blau patient, and we see it sporadically with no particular cause, and it really can produce lots of changes. Here's some other examples here. Very extensive chorioretinitis. Whenever they get these peripapillary nets, there's always a risk that it's going to progress into the center of the macula. Okay, so that's all that I have to